me, data diversity is the amount and variety of data that we have. In the UK, we probably have the best data sets in the world, and I think we are envy of the world. If we look at it, we have one NHS number, which is linked to a number of data sets, including primary care, secondary care, census, and all of these data can be linked together with positivity tests for COVID and also outcomes, and then mortality data sets through ONS as well. It's a tremendous resource that we have in the UK. The access that HDRUK has made available is incredible, and it's happened at such a pace. We've suddenly got access to a number of data sets we weren't aware of that we could get access to. And HDRUK have also informed us in a timely manner when we have queries as well. Because of that, we are now using a number of data sets. The data sets we initially started was using the Office of National Statistics, Trusted Research Environment. But because of our connections and our meetings with HDRUK, we are now going to be looking at the Cardiovascular Disease COVID UK project through the BHF Data Science Center. We're looking at Q Research database and the ISARIC database as well. Our original UKRI grant was focused on UK Biobank to look at risk factors, modifiers, and mediators of excess risk of COVID-19 outcomes in minority ethnic health groups. At that time, this was the main data set we had access to linked to COVID-19 outcomes. However, Biobank is not representative of the wide UK population and has limitations in generalizability of the findings, and the sample size is also too small. We were already working with the Office of National Statistics, and now we've partnered with them to translate the analysis plans that we had in the UK Biobank to the larger English data sets. And we're also now working with SAIL as well as the Welsh data set as well. The link between differences in health status and overall deprivation to increased risk of COVID-19 is very, very complex. We're not still sure what leads to worse outcomes in this population. But what we do know is that the COVID-19 has disproportionately affected certain populations, and these include deprived population, ethnic minority populations, those with chronic comorbidities, elderly, men, and some of these are interlinked. So, for example, deprived populations and ethnicity are very interlinked. More ethnic minority populations live in deprived populations. But we're now drilling down even further within these populations, because even within ethnic minorities and deprived populations, they are not equally affected. So we're now looking to see household size and occupations, and it's becoming clear that household size is an important predictor for worse COVID outcomes. Larger households, more people living in a household, such as household density, is definitely associated with worse outcomes. And we're trying to unpick this using the data sets we currently have. We're trying to look at a number of areas. These include the differential impact of risk factors such as cardiometabolic, obesity, and mental health on COVID-19 outcomes. We're looking at multiple long-term conditions and impact on COVID outcomes by ethnicity. The impact of public health measures such as lockdown on reductions in COVID outcomes. An important area over the next phase is going to be looking at immunization, uptake and effectiveness by different groups, and also long COVID in terms of survival and complications once people are out of hospital, or even those who haven't been admitted to hospital.